Thanks, Jared, and thanks to the stalwarts that are here for the afternoon session. So I have no disclosures that are relevant to this talk. So my objectives for this talk, I'm going to spend about the first half talking a little bit about some intra-aortic balloon devices. I'm going to look at a few things that can help us distinguish arterial from venous catheter positioning. And then I'll finish up with some findings on chest radiographs which suggest placement of a central venous catheter into variant veins. So I'm going to start off with this. This was an IAB placement film, came down intra-aortic balloon pump, and so we're looking for the marker. I'm sure everybody has seen these. And so it looks like there's a marker there sort of over the midline, which is a bit of an unusual position. But as you look at the exam, you'll see another marker, or identical looking marker here. So it looks like both balloon pump markers, and as I'll discuss in a minute, they often have markers at both ends of the balloon or projecting over the sort of midline of the chest. They're only about 8 centimeters apart here. And this is a sort of caution, all right? So one of my rules of thumb that I teach is that when you're assessing these balloon pump devices, the ones that have 2 markers at least, it's very uncommon in normal situations to visualize both markers overlying the chest on a properly collimated chest radiograph. Now, if they included most of the abdomen, you might see both. But on a properly collimated chest radiograph, you really shouldn't see both markers, and when you do, that's a clue to a malposition. And in this case, that's because a portion of the catheter is in the ascending aorta. Here's the balloon folded on itself in the ascending aorta. There's the marker in the ascending aorta. There's the balloon. All right, and then rounding back here, here's the balloon in the arch, and there's the marker in the descending thoracic aorta. So this one has become malpositioned into the aortic arch, and that causes foreshortening, and you can see this is the simulated radiograph from the CT. What's happened is the balloon is folded upon itself in the aortic arch, and the balloon has become apparently foreshortened on the radiograph with the 2 markers seen there. A little bit about assessment. So all balloon pumps will have approximately 4 millimeter metallic marker at the distal end of the balloon. For purposes of this talk, I will be denoting those in yellow. There are dual density markers that are sometimes seen at the distal end as well. I will also denote those in yellow. I will show you an example. And then some, but not all, balloons will have a marker at the proximal end. All right, all the ones that we use in our institution have dual markers on both ends, but there are some out there where there's only a marker at the distal end of the balloon. Those I will denote for purposes of the talk in red. So this is a typical marker overlying the aortic arch. It's about 4 centimeters in length. I've magged it up. This is one of those dual density markers. I don't know if you use them in our institution. We tend not to, but some of the patients that come in from outside with the catheters in will see these. I actually like these because when they're dual density like that, I know that this is the distal marker. All right, they never make apparently dual density proximal markers. So when I see that, I know that's the end of the balloon. All right, in terms of optimal positioning, they're typically placed so they're just distal to the takeoff of the left subclavian artery because this optimizes function and minimizes complications, both complications to the aortic arch vessels and to splanchnic vessels and renal artery. On a chest radiograph, this typically translates to somewhere between 1 and 2 centimeters below the aortic arch or knob. And so this is a balloon pump catheter. This is a typical femoral balloon, so it's placed from a femoral approach. There's the marker. It's about 1.5 centimeters from the superior aspect of the aortic arch. That's a good position. And notice that if this balloon has a marker at the proximal end of the balloon, it has been coned off the chest radiograph. Now, does positioning really matter? I think that's a reasonable question to ask. We worry about it all the time. The only data that I can find out there that looks at correlating balloon pump positioning and outcome was this study, and this was a retrospective review of like 400 or some balloon pump placements, and they categorized their balloon pumps into properly positioned if it was within 5 centimeters of the arch, malpositioned if between 5 and 10 centimeters below the arch, and severely malpositioned if it was lower than that. And then they looked at major complications such as limb ischemia, death related to the IABP, stroke, mesenteric ischemia, renal dysfunction, etc. And what they saw was a stepwise increase in complications. All right, the more malpositioned the balloon was. So yeah, it does appear that it is important. Balloon pump catheter positioning is important. Another thing to recognize is the balloon pumps only come in a few predetermined sizes, and it's mostly determined by the volume of the balloon. Most manufacturers make balloons at 20, 30, 40, and 50 cc's, and most clinicians want the largest balloon volume possible because that optimizes function. The volume of the balloon determines the length of the balloon, so the more volume in the balloon, the longer it will be. And these are select based on nomograms based on size, but you can see with only a few sizes to pick from that size mismatches may be quite common. And in one series, when you were considering the distance between the takeoff of the left subclavian artery and the celiac artery, I believe, they determined that size mismatches occurred in up to 70% of individuals. And usually the balloons are oversized. So in this particular example, this looks pretty good here. I'd call that a really nice positioning, but in the same day, the patient had a CT scan, and you can see the balloon is blowing up across the origin of the SMA and the renal arteries, and in fact, the distal tip is way down here. This is clearly a very oversized balloon for this particular patient. Now back to this case. This case has an additional wrinkle. So let me go back just a second. I'm going to mag up on the left axilla. Notice the clips, the skin staples here. I'm going to mag up. Notice this little Dacron tube graft, this little radiopaque graft coming in here. All right, that is a little graft that has been surgically implanted into the subclavian artery for purposes of accessing the upper extremity vasculature to place a balloon in a retrograde approach, a so-called axillary balloon pump. How many people have seen these in your institution? Yeah. You know, our clinicians started using them, and I think it was about 3 years before we actually knew it, because we would see these graphs and we wonder what they were. We finally figured out that they were putting these in to place the balloon from an axillary approach. So this is a newer technique. It's been around now 7 to 10 years or so. And in this technique, a tube graft is sewn into the subclavian artery typically, and then the balloon is floated from the above, and you'll have a distal marker now projecting over the abdomen typically with a proximal marker. And every balloon I've ever seen placed from an axillary approach has 2 markers, denoting the proximal end of the balloon. Now, why are these used? Well, they're nice for longer-term therapy because they can hook the patients up to portable pump packs, and they can ambulate while they're waiting. And these are often used as a bridge to transplant, or sometimes when they're trying to decide on an LVAD or that sort of thing, so they can get the patient up and moving around. So they're useful for longer-term therapy. But unfortunately, I think because of 2 factors. One, the patients are moving around, and secondly, because of the anatomy of this term, these things are prone to wander. All right, and so when you recognize that you've got an axillary balloon pump in there, you've got to be really careful because they will move around a lot from day to day. And this is the case I started with, where it's become positioned into the arch. There's the drive line. These things are usually driven with helium, and you can see the drive line there in the left subclavian artery, and there is the little Dacron tube graft in the left axilla. Now, what do I mean by wandering? They move around all the time. So here's another patient with an axillary balloon. It may be difficult to see, but there's the little tube graft there. And that's what tells me that they've got an axillary balloon. There's a marker. I don't see another marker on the film. That's probably the proximal marker. The balloon, the distal marker should be down there. That's day 1. There's day 2. All right, it's beginning to drift. drifting a little bit more here the next day. Okay. And now where is it? Well, it looks like it's down there, like it's been advanced way too far, which is pretty long for a drive line. But I noticed that there's also a marker here. So what's actually happened? In this case, because it was sliding down the descending aorta, they retracted it, but they retracted it too far, and a portion of the balloon now is going to be in the axillary tube graft. And again, the clue here that you have a malposition is the fact that you see both markers on the radiograph at the same time. Another wandering balloon. How do I know it's an axillary balloon? Because I've got the tube graft here. This time it's coming in from the right into the right brachiocephalic artery. There's the marker. Okay. Next day, there's the marker. Well, it looks a little weird in that location. Perhaps it's a little bit farther down the descending thoracic aorta. But the big key with these things is you have to have a high index of suspicion for malpositions. You have to carefully examine the film, and lo and behold, there's a second marker right there. Way too close together. What's happened? This one has popped over into the ascending aorta. Difficult to predict simply on its basis on the chest radiograph, but there it is on the CT scan. There's the marker in the ascending. There's the balloon in the ascending in the arch. And then the distal marker overlying the descending thoracic aorta. Remember that the ascending aorta and the descending aorta may superimpose on the frontal chest radiograph. So sometimes it's very difficult to distinguish a marker that's in the ascending or descending. But the clue here was the fact that I could see both markers on the radiograph, and the distance between the two markers is way too short for any known balloon catheter. That means it has to be either folded up significantly within the descending aorta, or more likely, this thing is just popped over into the ascending aorta. And the problem with that, of course, is you can cause injury to the ascending aorta. These things can actually pop down into the left ventricle across the valve and damage the aortic valve. They can pop up into the subclavian and carotid vessels, of course, and cause strokes and that sort of thing. So they do not like to have them within the ascending aorta. Okay, but again, it's really mostly just a very high index of suspicion for an abnormality. Now I'm going to skip through to this case. So this patient had a femoral balloon placed on day one. There's the marker. Looks like it's in a decent position right there. Okay. This is the next day. They were having chest pain. What's the difference here? Yeah, you've got a lot more soft tissue here along the aortic contour. Big difference here and here. CT scan shows extensive mediastinal hematoma. At this point, the balloon had been retracted back toward the femoral vessel. That's the proximal or the distal marker, I'm sorry. But you can see that there's actually a direct injury to the aortic arch right there with a little bit of extravasation, a small pseudoaneurysm, and a very large hematoma. This was successfully treated with an aortic stent graft, and the patient did well. Just to mention aortic injuries related to IABPs in life, they're uncommon, but they are more common in autopsy series. I suspect they're probably more common than we recognize if the patients had CT scans. Things that can happen: dissection, rupture, pseudoaneurysm is in that particular case. Now this one I really attribute to one of our eagle-eyed residents. This is a patient that came in, they had an MI, they went to the cath lab. They had a stent placed, I think, in the LAD, but they were continuing to have problems with cardiac output, and IABP was placed. Excuse me. And they continued to have chest pain after they came back from the cath lab. And our astute resident on call noticed that the aortic contour here seems awfully wide. Now, unfortunately, we didn't have a comparison. So it's, I think, a tougher call, but I think it's a reasonable call here. And because of the ongoing chest pain and the widening of the mediastinum here, a CT was performed, and you can see that they have a dissection And there's actually the entry tear, which I think is probably right where the tip of the aortic balloon pump was. At this point, they had retracted it more inferiorly, probably a direct intimal injury with a dissection occurring secondary to the intra-aortic balloon pump. Okay. All right, so those of you interested in more information, this was a great imaging essay last year in radiology, cardiothoracic imaging. I urge you to take a look. All right, so let's turn our attention a little bit to other catheter placement. This is a patient who had a PIC placed and a chest radiograph was obtained, and this is another patient with a PIC placed also from the left arm. Both of them are in variant positions I think we would recognize. So questions I always ask myself when I see a variant positioning that I don't understand on the radiograph is it intravenous? It's just in a vein I wasn't expecting it to be in. Could it be intraarterial? Is it extravascular? That happens occasionally. And then I'll usually turn to the clinicians and I'll ask them, are you getting blood return? Because if it's extravascular, you will not. If they are, then perhaps you should check blood gases or waveforms with pulse with a transducer device to see if it's arterial or venous. And those are good ways clinically to sort of work these things out. But there are some other radiologic clues that can help us as well. Okay. So what I want to introduce is this concept of the so-called scalene tubercle. And the scalene tubercle is this little bump on the first rib where the anterior scalene muscle inserts. And it's a very useful landmark on chest radiographs for distinguishing arterial from venous positioning of catheters. Notice that this catheter arches well above the so-called scalene tubercle. It's coming down on the left, probably into the aortic arch. This one is also arching on the left and curving down along the descending thoracic aorta, but it is projecting below the scalene tubercle. The artery typically projects above, the vein typically projects below. Let me show you that on a CT scan in a completely different patient. Here's the scalene tubercle as we go through. It's this little excrescence of bone here. And I'll just let this run through a couple times. You can see the vein anteriorly projecting at or slightly below, the artery arching well above the so-called scalene tubercle. I'll just let that run a couple more times to get a feeling for the coronal anatomy. So coming back to this one, this catheter is arching well above the scalene tubercle. It's coming down. Lateral view, looks like it's coming down into the ascending aorta, interestingly enough. We would predict this to be an arterial catheter placement, which it was when they put a pulse transducer on it. This one, on the other hand, is arching well below the scalene tubercle, and on a lateral view, it's coming down in this fashion. We would suspect this to be a venous catheter, and on pulse waveforms, it was indeed. What about this one? This patient had a catheter placed in the field. They thought they were placing an IJ catheter. Patient had a large right effusion. Clearly, the catheter is taking a weird position. I called up the ER, said, this catheter doesn't look like it's in a normal position. They said, yeah, we know, we've already checked it. We put a pulse waveform on there, it's arterial, we're getting ready to pull it. Good idea or bad idea? Bad idea, right? I said, you better hold on. I agree. I think it's probably arterial. It's arching well above the scalene tubercle here, probably going out the axillary artery, but there's no way you're going to be able to hold pressure on that. This needs to be removed under controlled circumstances. They consulted vascular surgery. Let me see if I can go through here. They wanted a CT first. There's the catheter. And here's the catheter coming here. It is sort of contrasty. I apologize for that, but it's actually hitting the top of the subclavian artery. They thought they were sticking the jugular, but they stuck the top of the subclavian artery, and somehow they made this very acute angled turn and went out the axillary artery. Okay. Remember, though, that when you identify these arterial placements, particularly centrally, they need to be evaluated and potentially removed under controlled circumstances. This was a patient with a lung cancer. The cancer had progressed. He had complete collapse of the right lung. At some point, I think during one of the rounds of chemo, they got septic. They had a pneumonia here on the left. They had a pre-existing right-sided port catheter, but because of sepsis and need for circulatory support, a left-sided catheter was placed and was coming down here. And I admit I was fooled by this one initially. I figured, well, that's probably just going down the SVC, which is displaced to the right. However, I noted that the distance between these two catheters seemed wider than your typical SVC, right? I mean, that was probably 2 or 3 centimeters right there. So I got a little bit suspicious. Plus, with the recurve of the catheter back in this direction, I started wondering, could this potentially be arterial? A CT was obtained, and you can see, in fact, it is arterial right there. So the key here, I think the take-home message is to use all the information you had. If we didn't have this right-sided catheter, I'm not sure I would have tumbled to the fact that this was arterial, to be honest with you, because with all the shift of everything of the mediastinum and whatnot to the right and rotation from the collapse. But use all the information that you have. All right, back to this one. What vein is this one in? It's coming down the left side of the mediastinum. Right, exactly. Left side, persistent left side superior vena cava coming down along the left. Here is a CT in a same patient but a different date, and there it is curving inferiorly into the coronary sinus. There it is on the lateral radiograph, typical path of the superior vena cava. So this is a little diagram I cribbed from one of my colleagues, Travis Henry, just to point out where these variant veins tend to run. So a catheter in a left-sided SVC tends to come down along the mediastinum, and if it continues inferiorly enough, it'll sort of take this hockey stick appearance into the coronary sinus. They rarely go that far unless it's a pacemaker catheter or something like that. But anyway, now occasionally you'll see one placed in the left superior intercostal vein back into the accessory hemiascus system. Those tend to take this little dipsy doodle around the aortic arch and then come back into the paraspinal region. A catheter placed into an internal mammary vein will parallel the sternum and manubrium, as you can see here. All right, I have seen 1 or 2 catheters over 35 years that were placed into the left pericardiophrenic vein. Never one into the right, but one into the left. And they tend to sort of curve out like this. All right, and then occasionally you will have anomalous pulmonary venous return, both left upper or right upper lobe, where the catheter could take a really bizarre appearance like this. And on the right side, not infrequently, we will see positioning into the azygos, and those sorts of catheters will take sort of this dipsy doodle along in the region of the azygos arch and then come back into the paraspinal region. So I'll look at a couple of these. Here is a graft catheter that was placed intentionally into the azygos vein. You can see the course here. It sort of takes this turn posteriorly into the azygos arch and then back, all right, along the spine, typical course of the azygos vein. And this is what it looks like, the course of the azygos vein on the lateral radiograph. This is a patient with a left-sided PIC, and at first glance, it looks like it's coming down the descending thoracic aorta. A couple points here, though, it is projecting below the scalene tubercle, so it probably is venous, and it's also taking this little dipsy doodle here along the aortic arch and then coming back here. So it's more likely that this is going into the left superior intercostal vein to the hemiascus and or accessory hemiascus, as you see back here, and that's the typical location. This patient had a brachiocephalic venous obstruction. It was dilated as a collateral, as you can see here, at a different time. Here's the left superior intercostal vein. Here's the accessory hemiascus coming down along the aortic arch. Now, one of the most bizarre catheter placements I've ever seen. This is coming down, terminating out there. So the first question I asked the clinician, are you getting blood return? Because I was worried it might be extravascular. And they said, no, we got great blood return. The pulses looks like it's venous, so we have sort of a venous waveform on it. But the blood gas suggests that it might be arterial. And so that was sort of bizarre. Anybody have any idea where this one's going? Yep, absolutely. This patient actually, fortunately, had a CTA done a couple weeks previously, and you can see that they have partial anomalous pulmonary venous return on the right side. And what's happened, of course, is the catheter is going out there into the right middle lobe vein. So, sort of bizarre. I don't know if anybody could ever make that shot again intentionally, and I'll probably never see another case like that. All right, I'll finish up with this one. This was a woman that was undergoing some sort of breast surgery in a surgery center, started crashing, did not have a central line in, so the anesthesiologist in a crash sort of situation put in a right-sided central line, and they weren't getting blood return, or weren't getting much blood return. So they got a radiograph, and we have this radiograph. Now, we don't have a pre-op chest film, but I think we'd all recognize this isn't really going where we think it should be for a venous catheter. And also the mediastinum looks pretty wide here. So there's a big concern, not getting much blood return, etc. It might be extravascular. So when they saw this, they sort of instinctively said, well, this isn't going to work, and they pulled the catheter out. And the patient continued to do poorly. Their mediastinum is a little bit wider. This is about 30 minutes later. Brought the patient over for a CT scan. And on the CT scan, what you can see on the initial images, there's contrast I should point out they were injecting from the left side. That's important. So the left-sided injection, not from the right. You can see some contrast material here in the brachiocephalic vein, the SVC, but it's sort of stasis there. You can see that the right ventricle is compressed. There's high attenuation material within the pericardial sac here, a dilated IVC with reflexive contrast and a fluid level there, all suggesting markedly elevated right-sided pressures, and this patient was in pericardial tamponade. And then a delayed image was obtained because they also wanted a body CT, so they scanned the chest, reset, scanned the body, and you can see there's frank extravasation of contrast material into the pericardium. So clearly, I think it was probably an arterial stick. They weren't getting blood return. It was bleeding a little bit, and unfortunately, when the catheter was pulled out, it just continued then to bleed very rapidly into the pericardium, and as you can imagine, the patient did not do well. So that's why it's really important, particularly with suspected arterial sticks, that the case be evaluated for removal under controlled circumstances. So just to compare and contrast, 2 more PICC lines. I mean, how many PICC lines have you seen put in the artery, right? We don't see them all that often, but it does occur. Here's one. It's arching really high, projecting over the scalene tubercle, and then coming down over the course of the ascending thoracic aorta. It was replaced. This is the same patient the next day with the characteristic broader curve of a venous catheter projecting below that scalene tubercle as a landmark. Okay. And with that, so last thoughts I'll leave you with. Accurate assessment of catheters on radiographs requires, first and foremost, knowledge of relevant anatomy, knowledge of the catheter and or the device, for instance, knowing whether it's an axillary or femoral balloon, understanding the possible complications of that device, and most importantly, a very high index of suspicion for malpositions, etc. Thank you very much for your attention.